Good evening, everybody, and welcome from Queen Elizabeth Foundation. Absolutely delighted with our speakers tonight. In fact, if I'm absolutely honest, I'm a little starstruck, having spent many, many years in the NHS. So thank you to both Professor Stephen Powis and to Dr. Yvonne Doyle for joining us tonight. But also, I don't want to forget our own internal member of staff, Rita Asamoah, who's our Director of Operations. I'm absolutely thrilled for tonight's taking place, and you're very, very welcome, all of you. So I thought that today, being such a monumentous day, a year from our first lockdown, and we have to reflect today with 126,000 deaths. That's just a number that none of us ever really could contemplate a year ago. So how has it affected Queen Elizabeth Foundation, and how did we cope? Well, I don't think any of us dreamed that a year on we would still be isolated from friends and family, not able to go out for dinner or have holidays. But for those 126,000 families and for those that are in our care, that story is much more than worrying about whether we can go out for dinner or not. So today, being a day of reflection, we thought we'd just take a moment to show how QEF faced up to enable to support those who have never ever needed us more. At the first lockdown, our retail shops and our mobility services shut. Our residential services in Dorincourt and the Grange had already shut their doors a week before. We made that decision to shut those doors very early. We also had our sale at Banstead going ahead. We were moved into our new building. Well, that was the plan, but unfortunately, COVID hit and we were unable to move our clients and unable to bring two groups of clients together. At this point in time, things, I have to say, looked pretty stacked against us. The CQC were unable to come out and register our new building because they weren't able to come out and visit. And it felt like a long tunnel for us to try and come out of the other end. We were trying to get partial occupation in our new building by the end of April. This just proved to be impossible at the beginning. Suddenly though, once everything was stacked against us, in true QEF fashion, we found a way through and we fought through, and we've come through stronger and with greater purpose. We always face things not with a problem. We face them as how can we create the solution? And I'm hoping today that that'll be quite evidenced for everybody about how we're all doing that. We're very proud to be part of the NHS COVID response, and we are taking patients very quickly out of hospital, sometimes 3 or 4 days after a stroke, and that's covering South West London, South East London and Surrey and Kent and some Hampshire. Our clients do come from far and wide, and some in fact have come from as far as Manchester at the moment. Against all the odds, with the virtual registration completed, which was quite an event in itself, we opened for business, and we really meant business at this point. So on this day of reflection, I'd just like to take this moment to thank with immense pride my team from the bottom of my heart for the extraordinary efforts made to support the NHS and, we believe, save lives. We worry about not being connected with our families and friends, and we worry about not having our holidays. So just for 5 minutes, just reflect on what makes us grateful to be here and how we're going forward. On the day today when Kate Garraway talks about how she's finding her husband at 9 o'clock tonight, we have lots of Dereks in our service. We have lots of people who have acquired brain injury, some from COVID, some from other causes. Those lives have been turned upside down, and we're here to show you some of what we do as well today, as well as the great input that we know that Stephan and Yvonne have had to the NHS plan. So I'd now like to take this opportunity to introduce Rita Asamoah, who's the Director of Operations. She started at Queen Elizabeth Foundation last year in January, And let's say that that was clearly a baptism by fire. I think from that moment in time, I think for the first 6 weeks, we saw each other every day, and then we didn't see each other for weeks on end. We took it in turns in going in so we could support the services, but we reduced the number of people being in services. So I'm absolutely delighted to have you on board, Rita, and thank you for sticking with us and making a real difference, getting the service open, and hopefully we'll be all really pleased with what you're about to say. So I'm going to hand over now to Rita Asamoah.
Thank you, Karen. Thank you very much. That was lovely. Thank you and good evening, everyone. Thank you for joining us this evening. This evening, I'll be talking to you about our response to the COVID challenge and working in partnership with the NHS. By doing so, I'll be telling you about QEF's care and rehabilitation service and what we do, our new patients pathway, working in partnership with the NHS, managing COVID risks, and person-centered care during a pandemic. So as Karen just said, our journey here wasn't straightforward, but in a true QEF fashion, we soldiered through and we opened. And on the night that we came, we actually took an admission, so the service never stopped. So as you can see on the screen, that was our old service. We were there for over 30 years. And our new service, which is absolutely fantastic, state of the art. So what do? We are a neuro rehabilitation centre for people across the southeast of England. We support people to regain core skills and maximize their independence after an acquired brain injury, stroke, incomplete spinal injury, or other neurological conditions. Our specialist services are delivered by a team of healthcare professionals, including a consultant in rehabilitation medicine. We have a GP, consultant nurse, specialist nurses, therapists, and rehabilitation care support workers. Our integrated service provides holistic, person-centered programs of therapy and nursing care. In-house therapies include clinical psychology, speech and language, occupational therapy, physiotherapy alongside specialist nursing care. We work with the NHS, case managers, and community referrers. So as you can see from the building, it's a 48-bed service in Leatherhead in Surrey. It's purpose-built and reflects the needs of our clients. Absolutely beautiful. I'm actually sitting in our client's lounge, which is stunning. We have doubled our capacity by expanding further over the next 6 months. When we arrived here, we occupied the ground floor, and with the needs of the NHS beckoning, we have now come to the first floor. Each bedroom is spacious and ensuite with tracking hoist and accessible technology. So, CRC offers 5 pathways into our service. As you can see there, these 5 pathways have varying mix of therapies, nursing care, depending on the needs and funding of the clients who come to us. This ranges from 4 weeks of intense neurorehabilitation following a stroke, a slow stream neurorehabilitation following an acquired brain injury, or long-term care for neurological illness. These are not set in stone. We've delivered them, we've designed them, but these are pathways that we can always amend or develop or review as the needs of our clients change. So our partnership with the NHS has come a very long way. As QEF has provided expert neurorehabilitation over 30 years, we have worked with East Surrey CCG since 2017. supporting stroke patients straight from hospital. We currently work with 15 NHS trusts and CCGs across Southeast England. We view ourselves as a trusted partner to the NHS, taking people directly from hospital, reducing length of stays in hospital, and supporting patient flow through the system. We then facilitate clients' discharge home or to another suitable destination to continue their rehabilitation. So what do our clients say about us once they've had the experience with QEF? Marcus had a stroke and came to QEF after 10 days in hospital. And what he said is this. He says, I was in isolation for 2 weeks. I found that hard, but my room was spacious and there were lots of green views, which really helped. My biggest achievement at QEF is being able to walk again and to do my best with what energies I have in my hands and foot. I'm very thankful to God that he sent me straight here after 10 days in hospital. We are very proud of what we do, and we are very proud of our therapists and our nurses and our care staff who continuously deliver top-class service to our clients. So as Marcus just said there, with a 10 days isolation, because we are a care home, we follow the government's guidance of ensuring that anyone coming out of hospital has to be in isolation for 14 days. Coming to CRC, you have to have a negative result and you have to show evidence before we accept you from hospital. This is because we have been able to keep COVID from our environment. I mean, from the first lockdown, we did not have any COVID in our services at all. We have managed to control this to the minimum through the systems that we have put in place. Clients who have not had COVID have a rapid flow test on admission and then go into isolation. Clients have regular PCR tests. However, clients who have already tested positive for COVID are not tested for 90 days. This is because they are still shedding and they will still present with positive results. However, we ensure that all our staff are in their full PPEs and they support clients safely. The CRC has managed to put in place very strict COVID protocols, and it's much easier for us in this new environment. Because of the spacious bedrooms, with tracking hoists, meaning that therapists can work in isolation with our clients. Spacious communal areas mean that we can still have activities in a socially distanced way. We also have purchased a care dome where clients can see their visitors in isolation. We have accessible technology so clients can also make calls through videos to their families. We've done everything we can to ensure that our clients do not feel too isolated because we know the impact of isolation on their well-being. COVID has presented challenges across the NHS and in healthcare, and we are not the only ones. So the pandemic has ensured that once people come to us, as you can see on the screen, our clients feel that quite a lot. One, they lose that support network they have around them. In hospitals, they can probably see their visitors, but once they are here, that is very difficult. Families who act as a voice and help us to be able to understand the client better cannot visit. And that is really challenging on families who are very worried about their loved ones, but can't come and be by themselves. Wearing masks to deliver therapy isn't easy either, especially for speech and language therapists, for example. Being able to show a smile, being able to communicate through our facial expressions. And I think one thing we've all learned to do is how to smile with our eyes, because we no longer can smile with our lips because of these masks. Less social interaction with other clients in our services which normally helps to normalize it because people build friendships and relationships. Due to the lockdown, we can't access the communities. And this is so key to recovery because we know that people can practice road crossing skills and using money, and this has not been possible. Families are the ones who have actually suffered most out of it. The challenge is not only to our clients, the challenge is to our services as well. Our occupational therapists take it as part of their role to visit the environment where our clients live so they can advise them on what they require. This has been scaled down because of the pandemic. As I said previously, the wearing of masks are difficult in providing therapy for people who are non-verbal or have communication issues. Our staff are required to wear their PPEs, and this requires time. So once you come into work, you have to rush in, do your test, wear your gowns, wear your face masks. If someone is in isolation, you have to be in your full PPE gown before you go in. You can't just run to someone who's pressing a bell because you have to wait and get all those things on and then take them all off before you come in. And that provides its own challenges to us. We have also had staff shortages due to staff having to isolate. So that impacts on our staff who have to isolate whilst we bring others in to provide that service. Delivering intense therapy in a confined space isn't easy either. We know we have all these great grounds and great therapy areas, but if someone is in their room for 10 days, that is very difficult to do. Our staff have also suffered. They have had to work all through the first and second lockdown and all through this time supporting and making sure that they're doing what they have to do. This obviously has had an impact on their well-being and has had an impact on their mental health to a degree. The anxiety of having COVID is always present. The QEF way is to always find solutions, and we have supported the NHS through our person-centered outcomes. So our expert therapy and medical care to our staff are safe at all times. We make sure that we are outcome focused, looking at what people have to do, making sure that we are supporting our clients in the right way and providing the support they require. You can see on the screen the tip card that was designed by our therapy team. And this is to ensure that they can support and bring in the families and provide education and practical strategies on how the recovery can take place, empowering each person to build on their own therapy. We have responded to the increased demands, taking people out of hospital during the pandemic and reducing the pressure on the NHS. We have carefully managed the COVID risk by reducing and being strict with our staff team and being strict and locking down our service, as Karen said earlier. We locked down our service at the very first onset, and we are still very strict on this. And this has meant that we've managed to keep the COVID virus very low in our services. We are able to discharge clients home or to other suitable locations, and by that delivering on the outcomes that our contracts expect from us. So what are we doing moving forward? We look to maintain this positive relationship we have with the NHS. We want to use QEF services across the expertise we have across QEF. An example of this is our mobility service to deliver assessments to all our clients before they go home. As COVID funding eases and other services close, partnership with the NHS is more important than ever to manage COVID as a chronic illness and explore how best we can support non-COVID clients in the community through our outpatient services. We are looking to continue working in partnership with the NHS and continue providing person-centered care. Thank you very much.
Thank you, Rita. I am going to keep everybody on mute through this process, and we'll take questions at the end. But if you want to pass any questions for Rita, do just pop them into the chat and we can take them at the end. So thank you for that. Thank you, Rita. Obviously I know that, but even hearing it, it's still very moving each time I hear it. So now I have great pleasure in welcoming Professor Stephan Powis, who's the National Medical Director of NHS England. I'm really grateful for you making the time today, and any other day must be a huge drain on your time. So we're really appreciating you giving it some of that to QEF. So thank you very much. And Stephan, it's now over to you. Thank you.
Well, thank you very much. And it's a real pleasure to be here this evening. I'm not sure what it's like where you all are watching in to this, but as you can see behind me through the windows, it's a beautiful evening here in London. The sun has just gone down. I'm in NHS England's offices in Elephant and Castle. I can count on the fingers of one hand the number of times I've been here since the beginning of January, but as it happens, I'm here today. And there's a view of St Paul's probably just behind me that you probably just can't see, but it's a beautiful evening here. And indeed, with falling infection rates around the country, and that remarkable statistic that over half of all adults in the UK have been vaccinated against COVID, it certainly is beginning to feel like spring might have sprung. And of course, it's a real shame that Yvonne and I can't be with you here in person. But alas, for the reasons that we're all aware of, we can't do that sort of thing at the moment. So like many of our daily social interactions these days, we must get on with this using Zoom. Of course, one of the great dilemmas of doing this sort of thing by video is exactly what one should wear. Now, I've been working from home, as I've hinted at earlier, most of the time, and I spend my days working at home on calls, usually dressed in an old sweater and a pair of jeans. But as you can see, I've scrubbed up tonight, so I've got my jacket, shirt and tie on. But I'm going to keep it a secret as to whether I'm still wearing my jeans. I just have to remember not to stand up and walk around. Such are the benefits of home working and working on Zoom most of the time. Now, in January last year, the NHS in England moved to a level 4 incident, reflecting the gravity of the developing global health emergency with the emergence of COVID-19. And I'm sure you'll all agree it's been really a remarkable year. And for many of us, the charities included, a hugely challenging one. Personally, I've been overwhelmed by the passion, the focus, the dedication, and sheer determination of colleagues throughout the NHS, and of course throughout all our partner organisations, social care, our partner charities, and of course those who are caring voluntarily, as everybody has had to respond to the pandemic, working together, all of us working together to ensure that patients with COVID, and indeed those without COVID, have been able to receive the care that they need. As I've said, the same can be said for partners we work with, especially for the partners we work for, and not just want to highlight the work of NHS organisations. We certainly couldn't do the work that we do without valued partners in the voluntary community and social enterprise sector. And the response to the COVID pandemic, as I've said, has really underscored this. Queen Elizabeth Foundation have exemplified how organisations have stepped up throughout the period, providing care and rehabilitation to patients throughout, supporting patients who suffered strokes or seizures or other brain injuries. The multidisciplinary care that we've heard about and that quality organisations like QEF offer are at the forefront of our recovery post-COVID, both for patients who are still suffering from the effects of COVID and of course for the NHS's overall recovery from the pandemic. Now, I know rehabilitation can be a complex process, crossing many specialties and many professions. It enables people to return to full function or maximise functional recovery from illness, trauma and degenerative conditions. It covers multiple areas, including physical, psychological and vocational health. Rehabilitation requires close working and communication between primary care, secondary care, and of course the charitable sector. There are many crucial relationships between the public sector and excellent quality charities such as QEF that will be key over the coming months and beyond as we face, unfortunately, longer waiting lists and the long-term effects of COVID infection and potentially, unfortunately, future waves of the virus. As with many services, rehabilitation has been under significant pressure as a result of the pandemic, having to care not only for their normal cohort of patients, but also for those suffering, as I've said, with the after effects of COVID. This is all being carried out within a constrained environment for fundraising through the sorts of traditional methods that you use. And that's why I was particularly grateful to assist by accepting the invitation to this event and offering my support to the raising of funds for the Edward Guinness Appeal to help equip the new state-of-the-art care and rehabilitation centre that we have just heard about. So good luck, continue with the work. It is really valued by everyone, including, of course, us in the NHS. Now, you all know that today, as again you've heard, has been a particularly poignant day. It's the anniversary of the commencement of the first lockdown in the UK to combat the pandemic. And like many of you at midday, I gathered together here with colleagues at NHS England and NHS Improvement to mark the moment with a minute's silence. And I'm sure, like many of you, I thought about how over the last year, the pandemic has impacted on everyone in so many different ways, and just how many people have suffered from this terrible new virus. It's a time when we've all been reflecting over the last year, what has gone well, what could have gone better, and what we've learned. And I'd like to briefly touch on maybe three aspects of the pandemic response that have particularly struck me, all of which are interrelated. The first is just the sheer flexibility and agility with which health and care services have responded over the last year. Now, the NHS can sometimes, in my view, be unfairly portrayed as a slow to respond monolithic public service. But in the last year, I think we've all demonstrated just how quickly the NHS, with our trusted partners, can adapt and move to new ways of working to support patients and the public. And indeed, you just heard of some of the ways that has been done. Whether it's been the development of the Nightingale hospitals in record time, the changed and extended roles that many staff have had to take on, or the rapid establishment of clinical trials which have identified effective COVID treatments for use across the NHS, indeed across the world, I believe we have seen the NHS at its best. Now, secondly, emergencies often require innovation. And we have certainly seen lots of examples of innovation. We've seen the development of many new clinical pathways, remote monitoring for patients, for example, and indeed remote rehabilitation. Perhaps the most obvious example of innovation is the move to remote consultation in primary, secondary, and in community care. As an example, video consultations are now available in around 99% of GP practices, whereas at the start of the pandemic a year ago, this figure was less than 5%. Yes, the pandemic has truly changed the way in which we work. We now need to capture that innovation, the innovation, of course, that has worked the best for our patients and for our workforce, and make sure that we don't simply revert back to the old ways of doing things. So as we look forward, that is a real focus here at NHS England to ensure that we don't just go back to business as usual, but we keep the transformative processes that have changed everything for the good as we move forward. Now, third, I'd like to highlight the role that science has played in the response to this pandemic, and I'm pretty sure that Yvonne will want to touch on this as well. So on December the 8th, I was privileged to be in Coventry to witness Maggie Keenan become the first person to be vaccinated outside a clinical trial with an approved COVID vaccine. It really felt like an historic moment at the time, but that was really brought home to me a few days later. When I left Coventry at the end of that day, in my bag was the vial used for that first historic jab. The reason I had it was that the Science Museum had specifically asked for it, and I promised, with, of course, the cooperation of colleagues in Coventry, to make sure that I brought that first vial safely back to London. I delivered it to the Science Museum in person a few days afterwards and handed it over to the curator right next to the museum's display, which tells the history of vaccination, starting with Edward Jenner. And as I handed it over to Natasha McEnroe, the keeper of medicine at the museum, it was immediately transformed from an ordinary vial that many clinicians will be familiar with to an historic artifact. And of course, in doing that, the museum began to handle it in exactly the way you would expect them to handle a historic artifact, with gloves on and the care and attention that it deserved. So that made me feel quite nervous, because of course I'd been carrying it in my bag for around a week or so, bringing it back from Coventry, but here it was being handled like the historic artifact it now is. And of course, it will be on display in the Science Museum very shortly, and many, many people will look at it for probably hundreds of years to come. Now, if I wind back a year ago, it would have seemed highly optimistic to predict that by now, a year on, over half the adults in the UK would be vaccinated against COVID-19. But exactly that has been achieved, predominantly because of the huge scientific advances that we've seen in recent years in areas such as genomics, sequencing, DNA sequencing, in vaccine technology, and in data processing. So this has been a truly international effort, within which, of course, UK scientists have played a major role. And of course, it's not just around the science, I should point out, it is also around the delivery of the vaccine programme. And I really want to pay tribute to colleagues here at NHS England. In fact, a few floors underneath me is the nerve centre of where that vaccine programme is delivered from. And of course, colleagues around the country, whether it's GPs, volunteers, hospital workers, have been doing remarkable things in terms of delivering those vaccines at pace. I have, again, the privilege to see those figures on a daily basis. And on Saturday, I could see the numbers were approaching 750,000 in England, and you add in the devolved administrations and you get to those record figures that were announced. And it really is a remarkable achievement. But science and public health, of course, have been thrust into the public limelight in the last year and into public debate in a way that I certainly can't recall witnessing before, as of course have clinical and scientific leaders such as Yvonne and myself. Everyone has become an armchair epidemiologist, carefully watching the R number change from week to week. I call my mother most days of the week up in Scotland. She lives in Scotland, and she's always asking me about infection rates and what the data's telling us. Personally, I think this is a positive development, but I guess the question is how this level of discourse can be usefully maintained in the future. For example, wouldn't it be wonderful if we could maintain the same level of discourse around disability, around health inequalities? So let's see what we can do to achieve that same level of public debate. It's also worth remembering that while we've all been responding to COVID-19, we've also been busy ensuring that we remain focused on improving healthcare and the health of the population in general. Now, for me, that has meant continuing to work on the cardiovascular, stroke, and respiratory ambitions articulated in the NHS long-term plan. I'm the senior person who oversees that programme. And although it's been challenging, we've been determined not to lose momentum. And I'd like to pay tribute again to all our third sector partners who've helped us lead these programmes. In this case, it's the Stroke Association, the British Heart Foundation, and the British Lung Foundation. We've also progressed other things. So I've been progressing our review on the key clinical standards that we use within the NHS to assess performance. And we have just finished consulting on proposed changes to these measures in our urgent and emergency care pathways as potential alternatives to the current 4-hour A&E measure that you will all be familiar with. But if 2020 was challenging, 2021 will be sure to bring its fair shares of challenges. We have, as I've said, embarked on the largest mass vaccination programme in the NHS's history. And as we have done that, we need to constantly keep a watchful eye, as I'm sure Yvonne will describe, as the virus mutates and adapts, and we need to adjust our course accordingly. At the same time, we need to focus on treating patients whose care has been delayed or disrupted because of COVID. And all at a time when our workforce is becoming increasingly exhausted. We will certainly all be living with the effects of COVID-19 for some time to come. And again, as I've already hinted, we need to relentlessly look to the long term, improving healthcare and the health of our population year on year. When I reflect on the NHS long-term plan, which was published just over 2 years ago at the start of 2019, the pandemic for me has simply highlighted and emphasized the need to concentrate even harder on its key elements, whether that's on prevention in areas such as obesity, on reducing health inequalities, on key disease areas, as I've mentioned, such as respiratory disease, or on the need for digital innovation in healthcare, or in fact on its focus on partnership working across all local health care systems. The pandemic really has shone a light on all of these. And so as we go forward, I know the valuable partners that we work with, such as the Queen Elizabeth Foundation, will be with us on this long-term journey, because we all share a commitment to provide world-class, multidisciplinary, personalised care. Karen and Rita, a huge thanks for inviting me this evening. I wish you all the very best with the Edward Guinness Appeal and with your exciting plans for the Queen Elizabeth Foundation. And of course, later this evening, very happy to take questions and discuss the response to the pandemic further. Thank you.
Thank you, Stephen. Thank you so much. It's moving because we've moved through the story together as well, and I'm thrilled that you were part of that session today. We will take questions, as Stephen said, later, but I think there are, who knew that the letter R for all of us was going to become so important for the rest of our lives, but now we do, and we all talk about it. So maybe there are some real advantages to us all understanding the risks. So I'd now like to take my absolute delight in inviting Yvonne Doyle. Dr. Yvonne Doyle is the Medical Director and Director of the Health Protection Public Health England. You've got such a long title, Yvonne. I hope I got it all in for you. But we're absolutely thrilled you're part of the session today, and I'm going to hand over to you now. Welcome.
Can you hear me now? Is that okay? Thank you, Karen, and particular thanks to Rita. I really enjoyed listening to what you were saying, Rita, but also seeing what a lovely facility you've got, and very exciting to have got that off the ground in the year that we've had. And how wonderful for people who have had such a shock in life to see such a beautiful facility and such caring people. And I also commend you for paying attention not just to their physical needs in their underlying condition, but the fact that you've been able to keep them safe and secure. And that only comes with the greatest of attention and personal endeavour. And thank you very much for it. So I represent here tonight the Public Health Service for England, and indeed we have very warm relations with the devolved administration, so we take a UK-wide view. But I'm also part of an international endeavour on public health, and I'm spending quite a bit of time at the moment speaking to institutes around the world, north, south, east, west, finding out, what we can learn together. And I know you've asked for my role and also public health's role in this, but I think we should really, as this is a global pandemic, we should also see both the learning and the solutions as global as well. And this is a time to look outwards and to work together for, the benefit of the pain that we've been through, that we can build on the opportunities that might have come through this to learn to do better, but also to work together for a better future, particularly for those who are most disadvantaged now and have been most disadvantaged through this pandemic. So that's the sort of environment I'm in. But let me reverse back and just tell you the story of the past 15 months, which I think, as Stephen has said, are the most exceptional and extraordinary, and in many ways, the saddest of my career. And I was aware at the end of 2019, around the New Year's Eve time, that there could be problems in a new infection. We'd heard it through various sources. We keep a very close surveillance on global infections and hazards through the international health regulations and working through the World Health Organization. So we had heard these alerts that were worrying. By the 2nd of January, I had stood up a full response in Public Health England with my very good colleagues in there, my scientific colleagues, and the medics and the nurses who work in there. There are 5,000 people working in the Public Health England service. Many are working in laboratories, but there are medics, nurses, but also very good scientists, epidemiologists, as we've just described, but also very good people who've come to work in public health because they care about disadvantage and they care about making things better through the organized efforts of society, through working with populations and bringing their skills to bear, not just in the healthcare system, but also with the people in their everyday lives and getting where they get to. So these people, we stood up on the 2nd of January, and by the 8th of January, we knew that there was going to be a different year to anything we had experienced. We diagnosed, having developed a test, which was a really big issue. It was, how would you diagnose this? It was seemed to be new, novel. It was coming from the East. By the 30th of January, we had our first cases. By the end of February, we realized that the cases we were now seeing, although there were few, they were not linked to anything that we had seen before, that they were not linked to either cases that we already knew about or clear lines of where the root of where the original case might have been. So then we thought, this is really now spreading through the community. How is it doing that? And sadly, by the 6th of March, we experienced in England our first death. Now, I think when I look back on this now, I think we underestimate how little we actually knew. Although we knew there was this coming and there was a problem, we didn't know what this was. And let me just tell you what we didn't know, because I think that's something that's worth understanding now, and how much more we do know. So we didn't have a test at the beginning of 2020, but our clever people in Public Health England had actually managed to develop a test. That isn't quite as simple as it sounds. And certain countries had tremendous problems, and they weren't the countries you might expect, had tremendous problems actually getting a test that worked so that you could actually diagnose this. We didn't understand how many people could have this infection that didn't show any signs or symptoms at all. In other words, the asymptomatic. We didn't know that. We now know in this country that about 1/3 of people are in that category. And indeed, in other countries, it would seem to be more than that. That's quite profoundly important to know. We didn't know how the body reacted to the virus. We didn't know whether the body actually reacted quickly, made antibodies, what kind of antibodies, how long they lasted, what kind of immunity people would have. We had no assays for those antibodies because this was a novel virus. We didn't know whether it would behave in the form that we normally saw with infections, whether we'd have outbreaks or whether it would be individual unlinked cases. We didn't have any treatments, nor did we have any trials to implement any treatments. In fact, we did not know anything that could possibly treat this at that time, nor did we know the outcomes that people might experience. Of course, as Steve has said, normally it takes a long time to develop a vaccine against a virus that actually is effective and that works and that doesn't go out of date very quickly. So we didn't have any of that. That had to be developed. We didn't actually know how much NHS capacity might be needed for this, nor how many people might hit ICU, although we had serious suspicions about this and some very good work going on all the while. But these were things we had to find out as we went. We didn't know how our health protection teams locally, who go out and actually find people who have these infections and particularly get into dealing with outbreaks, we didn't know how those outbreaks would manifest in local communities and how the health protection teams, did we have enough capacity to deal with this? We had a very limited amount of evidence overall, and let me explain this one. So normally we would have a bucket of evidence that we'd use. We'd have obviously all the things I've said would come in. There'd be published papers, you could draw down the literature, you could adapt that to your population. We didn't have any of that. And the first evidence that we really had to depend on was modelling. And then eventually papers began to appear in the literature and we began to be able to adapt what was that telling us. And these were other populations that came from the East, it came through into Europe. Would this be the same in the English population, in the UK population? Would people experience the same thing? What kind of people would actually experience this first? How would it affect our population? So we were depending on modelling and the early papers. And then we began to see, sadly, the cases coming through Steve's services, through the NHS, through many of you I know here tonight. That taught us a lot, but we also had to set up systems to measure that. We had to find these patients in the research realm. We had to document what was happening to them with the help of the NHS, where they, how proportions it suffered severe illness and what proportions got home and how quickly, how long did this last, how long were they infectious, what happened afterwards, all of that had to be found. So we then added clinical information. But that wasn't enough either, because actually we needed to know also what happened then. How did people behave about this virus? How would people tolerate increasing restrictions on their freedoms? What did we actually have to do to control this? And how would people react to that? And I say this because in the first months of this, we were seriously worried that actually people would not tolerate those restrictions on their freedoms. In fact, that we might have civil unrest. So the country, supported by all of us, had to set up a behavioural set of science groups to tell us what might actually happen, to model that, but also to advise us. So alongside the clinical and the scientific and the virological, we also had the behavioural. And eventually, as those, and I know there are people here from local government, eventually, as we began to understand what the population would and wouldn't do, and it was much, much more than we realized, then we began to realize how we could work with the population, and to have expectations that they would tolerate and do. And they were magnificent, as Steve has said. They stood up to all of this. In fact, it was the complete opposite to civil unrest. People wanted to contribute to protection. They do wear face masks, they do stay at home. The majority of the population do comply with the most serious restrictions on their everyday activities. And life, as we all know, has changed utterly. The one thing, there were other elements of this, how people traveled. Did I know how many hundreds of thousands of people come in and out of this country and where they go and what happens and what happens in the context of a pandemic? That all had to change. And then finally, how, as a public health doctor, how do people actually live life? We think we know this, but actually what we have learned is profound about the different groups in this country, how people live, what happens in the various seasons, how people work, what happens at school, what people are concerned about, but also how they live life, how they work, what they do when they're locked down as well. What is it that needs to happen in those circumstances? Even down to, as you know, for those who are extremely clinically vulnerable, having to actually arrange that food was delivered to people. And we learnt some of that from international practice, but it all had to be arranged. This is now, we're only up to June of this year, and I don't want to take the whole time of this talk up in just saying that. But as this happened, the evidence changed. We learned more and more. We sadly learned a lot through things that I wish had never happened in your realm, how inequalities began to manifest. And yes, people with disabilities suffer serious physical disadvantage, perhaps, but that isn't why necessarily why things happen to people who are already suffering disadvantage. There's a cumulative sort of set of circumstances working against people when, you know, they're at a disadvantage already. And that manifests in various ways. And Public Health England did step in, and as soon as we had the evidence, we started to bring that into the public domain about how differentially this pandemic has affected various groups. And also, sadly, how it has affected people in various settings. And of course, you'll be very familiar with the situation for care homes and how that played out through this pandemic, and how we've all had to work so very hard to protect the most vulnerable. But, you know, sometimes always chasing the virus. Now we're in a different situation, of course. 15 months on, we now have vaccination as our way through this. But we also are asking people to continue to behave in certain ways to protect all of those, not just those who aren't vaccinated, but because we still have things to learn about how long immunity lasts, and also how the virus itself behaves. And being a clever virus, a rather clever virus, and not behaving like its cousins in previous iterations of coronaviruses, it learns to change quickly. And we now have better and clever ways of dealing with that too. So I am very hopeful about our science coming to bear on our futures. What I'm perhaps more concerned about is the impact long-term and the long shadow this has on people who've already suffered disadvantage, and those who may also have long-term effects from this year and the previous year. And that isn't simply so-called long COVID. It's how our young people will get back on their feet, having missed education, perhaps missed opportunities in the past year to get employment. How the country as a whole will face into several years ahead where, you know, I hope we bounce back very quickly, but, you know, the bounce may not be even either. And we need to be vigilant about, as has been said and is already in our lexicon, building back fairer. So there is a big job to do here to guide us together through this. And finally, I mean, I could speak a lot about all of this, and I don't want to. I want to listen to you and your questions. I want to commend my colleagues in the Public Health Service, in the National Health Service, but also those who have worked locally. And our discipline in public health is distributed very broadly through local government as well as in the national services. And it has been a great privilege working with local government. I, as director for London before I took over this role in 2019, just before the pandemic actually, I had the great pleasure of working with the 32 boroughs in the City of London, in London, and the Mayor of London. And it was one of the most enjoyable parts of my job. But, you know, how much I depended on those relationships throughout this country to help us all get through this in the last 15 months. I am hugely grateful for that. And I agree with Steve. We don't want to go back to where we were. We have now got a new, even stronger relationship with our partners out there in the field. And we need to work together to actually make it better for those particularly who will suffer disadvantage going forward. Thank you, Karen.
Thank you so much, Yvonne. That Was inspiring. Honestly, we know that you have to think about all the elements of this virus, but I don't think I'd actually realised about the behavioural group as well. I should know that. I've been married to a policeman for a very long time, so you'd think I'd probably thought of that, but I hadn't. So I think it's really inspiring that the whole thing you've all had to put together. And I think you must ask yourself, Yvonne, what did I do in life to take on this role in 2019? And I am going to pass back to Marissa, as we're now going to start taking questions. So questions in the chat, please, and we can start picking them out. We have got some questions that people have posed to us already. If you have questions, perhaps you could just pop them in the chat and we can highlight your question to Stephan, Yvonne, or Rita, or myself if you need to.
Thank you, Karen. Wow, what incredible speakers we've had this evening, and thank you to all of you. My name is Marissa Goldsborough. I'm immensely proud to be the head of philanthropy at Queen Elizabeth Foundation for Disabled People. And before I start with the questions, if I may, I would just like to say thank you to all of our supporters we have joined us at the event this evening that supported QEF. It really is amazing and we're incredibly grateful. And of course to all of you who are considering doing so, been inspired by what you've heard this evening. Thank you very much. As you can imagine, we've had quite a lot of interest for our speakers this evening with some pre-submitted questions, and please do keep them coming through in the chat. To start with, we have a question for you, Dr. Yvonne Doyle, from Tom Jameson at Able Magazine. He asks, how different might pandemic outcomes have been had the government taken a data over dates approach earlier in the crisis, or perhaps aligned its strategy more strictly with views and advice of Public Health England and NHS England, for example, with specific regard to the devastating figures we've touched upon this evening with regard to those with disabilities and other vulnerabilities?
Yeah, thank you. And I think always, as I said, the amount of stuff that we didn't know early on, and I think we collectively didn't know, was astounding. And in the first instance, we were depending on modelling, and actually it was data that were feeding into the system as early as possible. But you have to build up this knowledge, and you know, don't underestimate. I'm not saying this about the government, I'm saying it about ourselves actually, because I don't think it's right for me to speak for the government, but I can say it about ourselves. It is, you know, a huge responsibility not to get this wrong in a situation where so much could be at stake. And therefore, you know, you want to give the right data. And the dates thing, let me come to that in a minute. But, you know, getting the right data when practically nothing is published. And that was the situation really from about January until early March. It was a very worrying time for many of us. And I think, you know, anxiety has been an undercurrent of this pandemic for everyone who is trying to do their best and realizes how many, you know, how many mistakes you could make. And I've just come from these interviews I'm doing internationally because I want to learn how, you know, Korea and Japan and Singapore and the United States and Norway and you know, Germany, how they all think they did and would they change anything. And there isn't a single interview I've done where people have said, well, we got it right, you know, it's a pity about you. That's not the reaction I'm getting. Everybody is anxious still about this, and everybody realizes what a profound experience this is. Even those who actually have had a better experience, particularly in the East. And there are factors around that. Now, if you come to the dates element of this, the dates really only began to become an issue when we began to look at non-pharmaceutical interventions and what could happen when. And that really was determined by the way the virus was behaving in populations. And we had to learn that by how the virus is transmitted, how particularly the sociological elements of this, how people interact, how the virus behaves, and how the environment that everyone lives in either promotes or detracts from transmission. So again, I would come back to this, this issue of when you can, the dates of when you can do things safely. The data are when you know what you're talking about. You would want those two things to interact, but they didn't initially, and they couldn't, because neither were really, they were not two-hand in those early weeks. And I think people had to do the very best they could. And that was, a 24-hour endeavor. And there was so much to build. We could talk more about that, but there was so much to get in place in those early months. It was quite an extraordinary and worrying time.
Thank you, Yvonne. And we have a question for Professor Powis. 1 year on from the first lockdown, what would you say would be the key learnings, and as a result, will there be new additional measures put in place to prepare the UK for any future possible pandemics?
Thank you. So I think when you go back to the first wave of the pandemic, and Yvonne has spoken eloquently about the first few months and what we knew and what, perhaps more importantly, we didn't know. And obviously the peak was around Easter weekend in April of last year, and then a tail in terms of infection rates and hospitalizations in the few months afterwards. I think there were a number of things that we in the NHS learned. So the first thing to say is it was important at that point to realise that we didn't really know what was coming at us in terms of how many hospitalised patients that we would have, partly because the data, as Yvonne has said, that we needed to make those sorts of assessments and judgments was really evolving all the time, as we had experience from other countries and from the UK. And secondly, because we didn't know what the response to those non-pharmaceutical interventions, so those are the social distancing measures, the lockdown measures, what the response would be. So we had to ensure that we created the capacity in the NHS to treat as many patients as we feared might be coming our way. We had nearly around 20,000 as it turned out in the peak last April. We've seen more in the peak in January. But to do that, we had to step down a lot of elective care. And that was how we created the capacity. And I think my first point is that in doing that, we learned how we could, in the second wave, try and manage the epidemic by not stepping down that quantity of elective care. So one of the differences between the NHS, how the NHS has responded in the last few months compared to how it responded in the April wave, is that we've kept elective care going in a way that we didn't do in April. Now, there were good reasons why we didn't do that in April, but we've learned the lessons from that. And it's not just learning the lessons, it's the fact that the data is better, the testing data, the overall data or understanding was much better going into the wave that we had in the winter that allowed us to keep those services going. So that is one piece of learning. We learned how to treat COVID. So we have seen fewer patients requiring intensive care in the second wave. That is because of the great trial work that I mentioned that we've done, and you will have maybe seen in the press today that we've been talking about probably around 1 million lives saved around the world today because of the discovery that dexamethasone is able to reduce the impact of the virus in people, and that was the result of a clinical trial set up in the NHS at speed and pace, another thing that the NHS can do that many other health systems can't do. So in the second wave, we've seen fewer people in ITU, use of dexamethasone, but also because we learned how to manage people and how to manage their oxygen requirements. So the learning from the first wave that clinicians had moved into the second wave. And we also expanded our ITU capacity over the summer. So we provided more ITU beds so that if we did need to surge again, as we did in the winter, that we would have different areas to surge into, and we would have more underlying capacity. So there are many ways in which we took the learnings from the first wave into the second wave. But I think the nature of pandemics is that you learn all the time, and we were going to have to live with COVID, as I've said, for months, years to come. We will continue to learn, and the way we manage this will continue to evolve as experience is generated, as data is generated, and of course, as we learn more and more about how this virus is going to evolve.
Thank you, Stephen. And we have a question for Rita, please. You may have seen in the media today the government are considering potential changes to the law to ensure care staff are vaccinated. Are you able to share with us about the uptake across QEF services with our care staff, please?
Thank you for that. We have been very fortunate in that we have about 100% uptake in one of our services. And in our two other residential services, we have about 80% uptake. And those who haven't actually taken it up, it's because they've tested positive in the past. And as you know, there is a period before you can take up the vaccine. So for QEF, we have been very fortunate. But in every situation, we will just follow government guidance, and we will wait and hear what the guidances and our part to play in it. But yes, we will follow government guidance in this one as well.
Thank you, Rita. We have a question that I think applies to both Yvonne and Stephen, really, that I think many of us would be quite interested to hear about. What's it like giving advice to government ministers, and do they always listen?
Steve can answer first there. He does more of it.
Oh, sorry, Stephen, it was so on mute. We can never do a virtual event without at least one occasion of a mute. Yvonne, do you want to perhaps go first? If you could be so kind, thank you.
Yes, of course, and you know it is our duty, and this would be to local politicians as well. It is the duty of those who are, you know, in these roles to provide good quality, high quality, scientific, medical, clinical, epidemiological advice of the highest quality. That's our job, and that is received by politicians. It is their decision then as to how they wish to use that. So that's the relationship. And it's a good relationship, and it's a needed one, very needed. And I cannot comment any more than it's my job and my colleagues' job. And I have to say I'm very proud of my colleagues because they provide really superb advice. And you know that it's good because we keep being asked to give it. So that is the best thing I can say about it. I don't comment. It is not my job to make the decisions. These are very difficult decisions, and they're often very nuanced. And that is not my role. My role is to ensure that the best possible material is there, and to support my colleagues in providing the huge range of advice that they give as well, so that collectively we're proud of what we're doing.
Yes, so sorry, I was trying to unmute, but it wouldn't let me, but I think I've unmuted now. So as Yvonne says, I think the first thing to say is giving advice to ministers and government is part of our jobs. So that is what we would do before the pandemic, and it's obviously what we've been doing during the pandemic. So that aspect is not new. I think what has been different is just the amount of advice that we've had to give, and the frequency with which we've had to give it, and the rapidly changing circumstances under which that advice has to be given. And you know, we are both drawn much more into the heart of those government discussions on a regular basis than we would in normal times. But this is a health emergency, and so it's completely right and correct that clinicians and scientists who have expertise in these areas will be drawn into the heart of those government decisions. So the fact that we have been, you know, doing a lot of it is not unexpected, and is quite right. the second point I'd make is it's not just about giving advice to ministers. We talk to lots of politicians. I regularly brief MPs from all parties. In fact, I was doing one such briefing today with Jonathan Van Tam. Yvonne does those as well, because I'm on those briefings with Yvonne from time to time. So our job is not just to advise government, but is to provide advice and briefings to politicians across the entire spectrum. And so we have continued to do that. We do that in normal times, and we've been doing more of it. And the third thing I'd say is that my experience is that we are listened to thoughtfully and respectably. I mean, people, politicians, again, my experience over the last year have been generous in their thanks for the hard work that scientists and clinicians have been doing in assessing what is happening and providing that advice. And I know we are listened to. I think, as Yvonne says, that's reflected because the advice is requested, but also that it's acted on. But clearly it's the job of the politicians, and particularly the job of the government, to act on that advice and to take into consideration not just the advice that we give, but the advice that others quite rightfully give as well. And it's a really tough job for a politician of whatever background, of whatever party, to have to make those decisions. But it is their role. They understand that, we understand that, and that's how it works.
Brilliant. Thank you, Stephen. I have a question for Rita next. How do you think we can get better at working together to share best process across the care sector? I know you touched upon earlier with regard to how QEF has been so successful in containing COVID. How do you think we can take those learnings to the broader sector?
So, I mean, what we're doing today is sharing our practice and sharing our learning. So this is a way of doing it. And hopefully once the services open up more, we can be sharing the learning by inviting people through our services. We are really keen for our partners to see what we have to present. And also through provider meetings and provider conferences, sharing what QEF has managed to achieve. We are really keen to share that expertise and our successes as well.
Thank you, Rita. We've had a question from Kate, who's again directed at both Stephen and Yvonne. She asked, we'd be interested to get your views, please, on what we've learned with regarding to what we can do to support communities in order to understand issues and barriers, to make sure we get communication right and culturally appropriate, and how we can take those learnings forward with the support of community groups. If we could go to Stephen first, please.
Yeah, and when I said politicians were respectable, I meant respectful. I'm sure they're respectable too, but that was the word I was looking for. Anyhow, yeah, so I think working with communities and groups that for various reasons find healthcare difficult to access is a real important component of the response to the pandemic. And Yvonne might want to talk about this in terms of testing and tracing, because that's a challenge in the testing and tracing services. But one of the areas where we're working with communities very closely at the moment is, of course, in the vaccination programme. So the uptake of vaccination has been spectacular, and for reasons of clinical risk, we started with the older members of our population, including me. As it happens, we've got to my group a couple of weeks ago, so I got vaccinated. But the uptake in the over 80s, the over 70s, coming down into the over 60s has been phenomenal. Well over 90% uptake. We're seeing 95% or more. But there are still some people who for various reasons, haven't been vaccinated or reluctant to be vaccinated. And some of those are in particular communities, whether it's faith groups, ethnic groups, or particular communities. And often it's those communities, as I've said, that in other circumstances don't interact with health services in the way that I would like and we would like, for a whole host of reasons. So we've had to really work hard to get the information to those communities, to work with the leaders in those communities to understand if there are concerns around vaccinations. And I think the thing I would say about it is there's no one size fits all here. I was down in Greenwich a few weeks ago. They have a vaccine bus, and I was outside just opposite the Royal Naval, or the old Royal Naval College, the University of Greenwich grounds, with the bus, talking to the people who were running it. And the purpose of the bus was to take the vaccine program to local communities rather than asking people to come to get vaccinated. They were talking about how they were interacting with the local Nepalese population. They have a Nepalese population, and the particular information that population required, the particular reasons why the vaccine rate had been a little bit lower, and what they were doing to improve it. And it was a really clear example of the approach you have to take to one particular community. And that might work with that community, but it might not work with other communities. So I think the lesson for me on working with communities is that it really does take that sort of detailed, bespoke approach with each particular community to understand their needs, their concerns, how you can best help them to access the healthcare that they need.
Yeah, I just picked up somebody's question about children with disabilities, and given the context we're in, I thought I might just mention that the current vaccines are not licensed for children, but the good news is there is research going on to see whether children could be vaccinated. And of course, we've started vaccinating children for flu some years ago, and it takes a while to get that up and running. But eventually, I would hope that for those who need it, for anyone who needs these vaccines, that it is licensed and there is confidence among that population to accept it. So that's where it is just at the moment. The important thing to protect, all of the population is for as many of the population who can accept the vaccine to get it. And that creates in itself a protective film, a protective realm over those who are very vulnerable. And I agree with Steve. I'm not going to add to what he said. He's absolutely spot on that. The essence of, getting to communities that actually can benefit is to work with those communities. And you can only do that by working locally. And that is one of the big lessons of this pandemic, is how very responsive and agile the local services have been. They've been magnificent. And this can change. It can change whole populations as well as individual groups. So we now know that places that had very good engagement on mass testing actually have lower rates at the moment than those who hadn't. So it does make a difference. You can do it by population, you can do it by individual group. You have to work with the local people.
Thank you very much. We've had a question, I think it's for Yvonne, but do correct me if I'm wrong. It says, well, actually, no, on hindsight and reflection, I apologise, I think it may be one for Stephen. It talks about how rehabilitation providers have found it quite easy during the pandemic, and it's been facilitated in many ways to work with funders and to get people cleared quickly from acute hospitals, which gives immediate access for rehab for patients and avoids what could previously be quite lengthy delays. How do you think we can ensure that this continues in the future, please?
Yeah, thanks for that question. So I think one of the ways in which we ensured that the capacity was there for the NHS was to get much more efficient in our discharge processes. And I won't go into the various details of how we did that. It included, as you probably know, changes to the way discharges are assessed and some of the funding mechanisms through government. But I think what it highlighted is something that I think we already know in the NHS, in that we need to do better at getting people out of hospital when they no longer need that hospital care. And prior to this pandemic, 2 or 3 years ago, I was writing about the potential harm to individuals in terms of muscle wasting, thinking particularly of the elderly, of prolonged stays in hospital when that hospital care was no longer required. So I think in my talk, I highlighted the sort of innovative changes that have been made during the pandemic and how we need to reflect on those things that have worked best for patients and for staff and how we need to continue those. And I think that those discharge processes and that whether that's to home or whether it's to a community service or to a care facility of whatever nature, I think we need to reflect on what worked well. And although it's never possible to maintain everything that you do in an emergency, and quite rightly some things you reserve for that emergency, I think it is possible to take some of the learning out of it and work out how you would use a transformative process to maintain that during what we would recognize as normal times. And I think just one final point. So I think again rehabilitation is one of those areas where again the pandemic will have shone a light, and we've talked about long COVID a little bit. We've talked about the increasing need for all sorts of rehabilitation. Rehabilitation, of course, as you all know, is a large spectrum of needs. In the areas I look after, stroke rehabilitation, cardiac rehabilitation would be examples of that. But I think, again, one of the things to reflect on the pandemic is how we can think to strengthen rehabilitation services going forward.
Thank you so much. We've had a question for you, Yvonne. You touched on it briefly. We have experienced a massive impact across the UK and indeed on a global scale with mental health problems which have been exacerbated by the pandemic. What are the two priorities for Public Health England with addressing that moving forward, please?
Well, the first thing is to acknowledge it, and this mental health was something that really has grown over the years as a good outcome in public health, that we're actually acknowledging that people have a whole body, body and mind together. And that was something that Public Health England had been working on intensely before this pandemic. The impact on people during the pandemic has been acknowledged. I don't think we've been able to address it adequately. We have a number of online pointers to that. Our mental health team has been very active in trying to ensure that people actually can use the mental health opportunities that we have. And we had a relaunch when the kids were going back to school of the access to mental health support for good mental health, not looking all the time for trouble, but saying this is how you can help and prevent things getting out of hand and so on. So we do all that. I think as we go forward, we need to look at and understand and also measure what the impact of the whole pandemic has been on people's overall health, taking body and mind into account. And we know already we've done this by measuring the impact actually on NHS staff and on some of our own colleagues. And, they have been very distressed. And one of the questions for me is how quickly might they recover, and what will enable people who, anybody under enough stress, will become distressed and will begin to show signs of poor mental health. And we need to understand how recovery occurs and whether there's a longer shadow from that. And this is not about, having lost relatives. It's just being under constant stress, being locked down. On the other hand, one of the things that has changed, we know, is that relationships have changed in this country. People appear to have had more time with their children. They're enjoying spending a little bit more time at home and not having the stress of, commuting and so on. So there's a balance here. On balance, we need to understand more about this, but I don't think anybody is going to ignore it.
Thank you so much. We are running out of time. We've had many questions, but we might be able to get a couple more in. We've had one come through for you, Rita, just asking what level centre is the CRC, and if you could outline the COVID measures we currently have in place and how they might change over the coming months, please.
So the COVID measures we are still in lockdown, so we are not accepting visitors into our service. Following the government's announcement to have one family member or one visitor, nominated visitor into our service. This has now happened. We started on the 15th. So we have one family member or one friend who comes into the service. They have to follow our COVID protocols, which is to get have a rapid flow test before they come, wear their PPE, have sanitizers, and take their temperatures before they come. They have to socially distance. They can only touch their hands and be in their own ensuite bedrooms, while staff obviously not stand or check, but ensure that people are maintaining those protocols. We also have our dome outside, which is a very beautiful thing. It's added its own class to our lovely building, and our clients can have visitors in there. We can also, based on government guidance, facilitate visits by windows. So those who want to actually stand by a window and have a conversation, that is also possible. So we're doing everything we can to be understanding and to understand the impacts that isolation has on our clients. In some very serious cases, we have agreed for clients to still be able to see families because we think their mental health is really struggling and it's hindering their recovery. We have made that call and we have taken it very seriously to ensure that people can still see family when it is really necessary. So those are the protocols that we have in place at the moment.
Thank you so much. One last question, if I may, for you, Stephan. I think everyone in the UK is rightly proud of the NHS and the response. But how well would you say the NHS was equipped before it happened to handle the pressures of the pandemic? And when will the plans begin for future-proofing our services within the UK, please?
Well, I think, as I said in my talk, I think overall the NHS has responded magnificently, and I'm just ever so proud and impressed and humbled by everybody's response in how they have stepped up to this. But of course that doesn't just happen by accident. It happens because the NHS prepares for these sorts of things. We have processes in place, mechanisms in place to respond to all sorts of emergencies. Fortunately, whether that's things like terrorist attacks or natural disasters or unfortunately pandemics. And when I said right at the start that we stood up a level 4 incident at the end of January, and Yvonne has already spoken about what we were beginning to learn in January, that's the highest level of incident management that we have in the NHS, and it means that the NHS was on that highest footing for several, almost 2 months before the full lockdown came at the end of March. And of course, during that early period, the NHS, if you remember, was doing things like managing the repatriation of UK citizens from Wuhan and from elsewhere in Asia into quarantine facilities in Arrow Park, in Milton Keynes. So there were all sorts of emergency preparedness and response going on. And that's because we planned for it, and that's because we have processes in place to do it. Of course, we will be taking the learning from this, and it's not over yet, and reflecting on how we can strengthen things going forward. And as I've already answered, we have been doing that as we've gone along. We've constantly been taking learning from innovations, from what we've learned in treatment in wave 1 into wave 2. So that process is always going on, but we've now been at either level 4 incident or level 3 incident for a couple of months from the end of July onwards for the best part of a year, and that is a long time to be managing incidents of this level. I still have daily, don't do Saturdays and Sundays now, we don't need to do that regularly, but daily incident meetings. Yvonne will have that at Public Health England as well. So we are still very much in that emergency response mode, and we will have to continue to do that for some time. So yes, we will be thinking and already thinking about what we need to take forward for the future. Hopefully pandemics like this come around once in 100 years or so, but that can't be guaranteed, and we'll always have to be watchful that there might be another one around the corner.
Brilliant. Thank you so much. And thank you to all of our remarkable speakers this evening. You've been absolutely amazing. We're really grateful to you all for your time. Sadly, we haven't managed to get through all of our questions. You've all been a very popular panel this evening. We will do our best to get back to everyone after the event. All that's left to say again is thank you, and I'll hand over to Karen for any closing remarks. Thank you.
Thank you. I won't keep you long now because I don't think I could follow that really. So thank you again, Stephen, Yvonne and Rita. Yeah, if you've seen the comments in the chat, that people are absolutely thrilled by your inspirational talks and speeches. So thank you so much for your time. Let's just take a moment to thank you as well on behalf of the nation. And I think the one thing we have to take from this is that there was nobody untouched in this. There's nobody untouched in the world by this. And I think that's the pandemic's effect that we have all had to make a difference and work together. And at QEF, we have a very strong set of values. And our values are everyone matters, everyone makes a difference, and everyone works together. Now, I can't think of a better set of values for how we face the pandemic. Maybe we knew that, but actually we've applied that, and we've applied that through all our workings, and hopefully that's one lesson we take forward and we continue to work forward with those values very strongly at the top of our agenda. So how can you help? I mean, when you reflect, I haven't maybe had that holiday, or we haven't spent that petrol traveling or commuting, perhaps you could just spare a little bit of that to help us make a difference. We need to continue this excellent work, and we need to continue to support the NHS and get people out of hospital as quickly as possible. But we also need to play our part in the vaccine programme. We've heard a lot about that tonight. I'm very proud about the uptake between the teams, and I know it's well above the national average of most care homes, so I'm phenomenally proud of that. We know we can make a difference by maintaining the vaccine programme. We know if we keep the social distancing, and we know we've got this to come for quite a while yet. It's not over, as Stephen said. So as the peak starts to fall, we're needed more and more. We're needed more and more to help in the rehabilitation, and that's really when our time is really now kicking in. We have immensely skilled staff, and they are giving independence and freedom, which is an amazing gift to give. This is not just a building for us. This is not just a building we've created. This is a building that has allowed us to do so much more by keeping the isolation and keeping people safe, but also keeping people engaged, as you heard, through the access technology and the actual, even the air system that we've put in the new build has allowed to keep everybody safe. Our client diversity in terms of how and what pathways we can manage has really increased, and that we know is going to be a challenge and challenge our own thinking going forward. We've currently got increased beds, and we want to continue to do that, and we want to keep the clients coming out of hospital as quickly as possible. It's challenged our own discharge plans. We are turning patients over much quicker than we ever have done, and that's, you know, given us some challenges too. And I think one of the messages I took from Stephen's talk was innovation. We've certainly had to think about being innovative, and we had to start from that from the very word go, even initially to survive. And now we're surviving, and now we're going to succeed. It remains a challenge for us though, financially. It probably remains a challenge for us in stamina as well. And I think we've heard that from across the NHS, but all partners that have been involved in the pandemic going forward. Resilience is key. But seeing the outcomes that we make by this amazing team makes it all worthwhile. We're forever indebted for people like yourself, Stephen and Yvonne, thank you, and for everybody who's played their part in this. But we're also indebted to everybody who supports us to enable us to give these great outcomes to so many people. I'm very proud to be the Chief Executive of Queen Elizabeth Foundation, and I say this normally very emotively at this stage, and I am emotive because we make a difference. We improve our outcomes and we improve people's lives. I can remember one small story I'm going to leave you with, which came from the last audience with. a young dad who, with help from us with his rehabilitation, speech and language therapy, was able for the first time to read a story to his son at bedtime. There isn't a bigger gift we could give a young dad, rather than talking to his son for the first time or reading his story. That precious gift is something that we really, really treasure. So thank you to everybody. If you're thinking about that holiday, I know you can't have it yet, so maybe you can help in a different way. Thank you for your time tonight. Thank you, Stephen and Yvonne and Rita again. Really appreciate it. But I'd like to end up on thanking everybody in my team that's on this call that gives so much to so many. And I think we should take the last moment to celebrate the NHS and everything they've done for us. Thank you.